Well, I'm going to introduce Ramona to this audience. Ramona Moldovan is a very well-known genetic counselor, a professional at the very small community of genetic counselors in the world. She's dual trained as a genetic counselor and psychologist, and one of the few genetic counselors who get the accreditation as a registered professional in this field. She is originally trained in Romania and now based in the UK as a senior lecturer at the Master Program of Genetic Counseling in Manchester. You all know that as professionals of genetic healthcare, we have the opportunity to know and to help people in very unique moments of their life, any unique circumstances of their life, special moments, difficult moments sometimes. So it's a challenge for us. But it's also a pleasure to be a genetic counselor and have the opportunity to know very unique professionals as Ramona is, and learn from them, share a lot of different life experience, cultures. And this is a pleasure I have had with Ramona. We have been working together for more than 15 years, publishing together, fighting, arguing for the promotion of our profession worldwide. And that's the reason I thank her to be here and share with us her knowledge, her experience in genetic counseling area. We are really having a special moment here right now because we have the second edition of the master course in genetic counselor at ICBAS. We have some students here, also students from the first course 10 years before. So I would like also to mention that this seminar was an initiative from ICBAS to promote internationalization of our courses, our expertise, and this master course is very unique also. That's the reason this seminar is very special. So at this moment, we have more or about 200 people with us from all over the world, America, South Africa, Europe, France, Spain, Belgium, Italy. So many thanks to them as well. We will allow them to put the first comments or suggestions or questions because of the time difference. And then we can stay with her for the rest of the experience. Thanks, Ramona.
Thank you so very much for the invitation and the introduction. It's really, really a privilege for me to be here. I'm very grateful that you invited me and you arranged this spectacular setting and this really good opportunity, I think, for professionals locally, but also internationally to discuss of these issues. I'm also privileged to feel at home for technical reasons. This is my happy place. And also the weather. I fly from Manchester, so I really feel like home today. So thank you very much for having me. I'm going to try to talk a little bit about my understanding so far in terms of the psychotherapeutic role that we have, or the psychotherapeutic dimension in genetic consultations. So I'm going to try to find a blend, a mixture between theory and practice, and then just to give you a feel of maybe some of the things that we already know from the literature and some of the exercises or some of the skills that we use in practice. So I'm going to try and do that. And I thought probably a first good example or a first introduction in my seminar today would be a small exercise I would invite you to do with me. And people in the room here have a piece of paper handy, hopefully. And those of you watching or joining from home, I'm hoping you have a document, a Word document or PowerPoint or anything where you can write a few notes and maybe share it with us at the end so maybe have something ready to write a few thoughts. And my hope is that you will write down in the next minute or so a very honest, intimate information about yourself. I'm going to collect the papers after, something that's really deep, something that's maybe secret, something that is maybe something you're ashamed of or very conscious about, something that you don't share with other people, something that you know makes you feel very uncomfortable, anxious, or sad. So I'm going for that level of intimacy. So if you can think of anything to write down, I'll give you a minute or so to do that. So am I okay to collect the messages? Be pleased to know that I won't. But I think what I would like to collect is your thoughts or feelings that stayed with you when you had to do that. When you maybe thought, is she serious? Or she better not be collecting this, or I hope she's not going to share this with anyone with anyone else. Or she will probably have her registration removed if she does that. So I think what I'm trying to get at is usually that is the level of report, that is the level of intimacy we expect from our patients. That is what we go for when we see our patients in any clinical consultations that we do. And I think many of you here are have patient-facing roles, and many of you here talk about the most intimate details in people's lives, whether that's health-related issues, personal issues, relational issues, our most, sometimes deepest, intimate, darkest personal secrets, information about ourselves that we have. And sometimes we have half an hour or an hour to offer that report or that environment where patients feel comfortable enough to share that information with us. So this is where I'm trying to encourage you to take with you today my talk, and maybe later if it's useful. So I will talk today a little bit about this report that we're trying to build with our patients. Sometimes we call it report, sometimes we call it a bond, sometimes it's therapeutic alliance. We talk about collaborative relationship, working alliance, counseling, or therapeutic relationship. So I think depending on the literature that you read or the discipline that you come from, it will have different names, but in a sense, it refers pretty much to the same thing. And I'm not going to go into semantics very much, but I do think it's important to just have our definitions straight and make sure we're talking about the same thing. And you'll see in a minute why that's relevant. So when I talk about psychotherapy or the psychotherapeutic dimension of a clinical consultation, this is what I'm trying to hint at. So we're talking about a psychological service that is provided by a professional trainer, a professional trained, that usually in the case of psychotherapy versus counseling, it assesses, diagnoses and treats mental, emotional, or behavioral disorders. And in the case of counseling, it's more focused on helping patients, individuals, families, or couples to cope with various difficulties, problems in pretty much the same areas as psychotherapy. So it's very much a communicational role where we help patients either to cope or to really treat some of the difficulties that they have. And those of you trained in clinical psychology or counseling or psychotherapy will be very much familiar with this. Those of you who aren't might benefit from knowing that psychotherapy really works. So we know, and I'm just giving you a very high level overview of the data we have, but we know that about 75% of the patients overall benefit from psychotherapy. So this is quite a good number to have in mind. So it really does work for most of us, not everyone, but for most of us, it really works. And the benefits that we have following psychotherapy are generally long lasting. So if we look at 3 months or 6 months or even 2 years later, we do see those benefits still there. And we also know that actually there are no significant differences between various forms of psychotherapy. There will be some forms of psychotherapy, such as CBT, for example, who tends to be a bit more investigated. So there are more trials looking at that. But actually, all forms of psychotherapy have by now quite good empirical support to show that psychotherapy works. Now, how does it work? And you're going to see why I'm slowly getting to the points in a minute. So how does psychotherapy work? Well, we know already that there are a few major contributing factors that tend to be responsible for the psychotherapeutic success. And there will be factors more related to the patients. So these are the skills or the resources that the patient brings into the session. That might be the social support, that might be religion, resilience. So there will be things that the patient brings in the session. Sometimes there will be things that the therapist will bring in the session, of course, some of his experience, sometimes even the personality traits, the training they have. So there will be variables more related to the therapist, and also variables or characteristics related to the process, such as the therapeutic alliance, some of the techniques we use. So there are many factors that tend to contribute to the success of psychotherapy. Now, those of you more familiar with psychotherapy will know roughly how much all of these factors weigh in. This is a graph that I'm very fond of, particularly because it's 30 years old and it's as accurate today as it was then. And we know that about 40% of the success in psychotherapy is actually explained by extra therapeutic factors. So these are things that don't happen in therapy. As I said, sometimes it's religion, spirituality, social support, things happening outside the therapy that the patient uses. There are relational factors. So 30% of the success in psychotherapy is explained by the bonds, the relationship we develop with our patients. So that's 70 so far for you. The fact that patients expect to get better. They expect change. They expect something positive in psychotherapy. We can talk about hope or expectancy, placebo effect. So that's about 15%. And the technique, the thousands and thousands of hours that we spend in training, myself included, are responsible for about 15% of the success. So give or take, these are the big numbers you want to remember when you think of what explains best the success in psychotherapy. So I think it's a good graph to keep in mind and remind ourselves every now and then. What also is very, very important is that all the therapeutic models agree on one thing. The most important contributing factor is the therapeutic relationship. That is the best and constant predictor of all psychotherapeutic approaches. This is something everyone agrees on. So there will be, of course, different psychotherapeutic models, and there's different trainings in different schools, but every single one will agree that the therapeutic relationship is key to success. Now, people will have, of course, different interpretation of what a therapeutic relationship is. And I'll walk you through some of the definitions if you want. And I think it's fair to say that a therapeutic relationship tends to be or can be approached as a nourishing environment, something that you facilitate, something that you make sure as a therapist, as a clinician, you have in place for your patient. The therapeutic relationship is very much like a catalyst, if you will. It doesn't change the nature of the relationship. It just helps it, it improves it, it enhances it. It's not healing in itself. And it's not something that is achieved at one point and then it never changes. It's quite fragile. It can have ruptures, it can grow, it can stall, it can grow and develop at different rhythms. So a therapeutic relationship is very much a nurturing environment, if you will. And in my personal view, it looks a little bit like this. It's very nourishing and it's very cathartic, and can be seen as a catalyst. Maybe the scientists in the room or in the audience will think of catalysts in a more chemical way, but it's very much the same thing. It really is a substance, a chemical ingredient that we can add to our interpersonal relationship, to our personal chemistry with the patients, and make sure we use that catalyst to grow the relationship that we have. So the counseling relationship or the psychotherapeutic relationship is pretty much the same thing, is a very collaborative relationship between a counselor or a therapist and a patient. It is that personal bond that I mentioned, and it emerges between them, and it facilitates change for the patient. Now, of course, those of you maybe a bit more familiar with psychotherapy or clinical psychology will know that the psychodynamic approaches were probably the ones who established the therapeutic alliance, the counseling relationship, and it was quite unbalanced at the beginning. And some of you will remember or see this and know this is the Freudian sofa with the chair hidden behind the patient, just to show you who has the power here. So it was a little bit more imbalanced to begin with. And then the Rogersian, the human-centered, the person-centered, or the humanistic approaches started to focus on more of a genuine, congruence, collaborative approach. And the dynamic of the therapeutic relationship changed quite a bit. And more recent and more modern psychotherapeutic approaches, pretty much like CBT, I would say, but absolutely the clinical consultations that we do in genetics, the genetic counseling sessions, have a more collaborative, equal relationship with our patients. We sit on the same chairs, we look at the same papers, we try to have the same goals, the same understanding of why we're here today, and try to work together towards the same goal. So the dynamic of the relationship has changed quite a bit, but it's important to know where we come from really and what we're trying to achieve today. So I think if we start to zoom in a little bit and look at how can we tell a therapeutic relationship is good? How can you tell in the sessions that you have whether or not and to what extent you have a good relationship with your patients? So if you think of any patients you saw in the last week or month, or any other human interaction, I guess we can extrapolate to that if we're generous. How can you tell you have a good rapport with someone? What is it that you look at? Is it the nod? Is it the smile? Does the patient do what you tell them to do? Is it the number of tears? Like, how do you measure? How do you know a relationship is good? And probably another good exercise that I'm going to leave that up to you is maybe to actually zoom in and think of a session that you are particularly satisfied with. Just think of something that stands out and you think, now that was a good session. What is it that went well? Like, what did the patient say? What did the patient do? How did you feel then? Like, what is it? Like, try to look at the anatomy of a session and then what is it that you think made that session good? But equally, we have to ask the difficult questions as well. So what do you think made you uncomfortable? Do you think of a really bad session? We all have them. So what is it that made us uncomfortable? Is there something that we did? Maybe we avoided to do something? Is it something that we thought? Were we trying to challenge something? Is it something that stayed with us when we went home and then we just kept thinking about it and maybe went back and back over and over again to ruminate or worry or get upset or uncomfortable about a session? So what is it that made a session not great? So these are like quite interesting self-reflective exercises that it's probably good to do every now and then, and most likely you do that as well. So I think it's not going to come as a surprise to know that there is solid empirical data to show that the therapeutic relationship is very much influenced by 4 big factors. The first one is empathy, our ability to put ourselves in someone else's shoes, to see reality through their own eyes, to feel what they feel for that particular time, and just show that empathy as well. The other factor is the positive regard, our capacity to unconditionally accept our patients and not judge them, even if we may not agree with some of the things they say or do, or even if the decisions they make may not be our own, but our capacity for positive regard, unconditional self-acceptance. That's the second. The third one is congruence, our ability to be genuine, to be authentic, even if it's just uncomfortable, and acknowledging that I'm a little bit uncomfortable with this. I'm not entirely sure where I'm going with this. I'm not entirely sure if you're disappointed with what I just said. I'm not sure if my English is good enough. I'm not sure if that example sits well with you. That capacity to be authentic, to be congruent, to show authenticity in the hope that if you do that, your patient will reciprocate and will do the same. And as I said, the more recent psychotherapeutic models very much focus on collaboration, the fact that we're trying to very much make sure we have the same goal in session, we're walking the same roads for the time being. We have consensus on our goal and on our means to get there. So that's the first main factor known to influence the therapeutic relationship. So I'm tempted to say that probably thinking of our best and not best sessions will have something along these lines somewhere there. I think you know where I'm going with this by now. And you can probably see why psychotherapy and genetic counseling have so much in common. And I'm sure many of you know that, and I do apologize for being redundant when I show you the definition of genetic counseling, but it's very much that process of helping people to understand and adapt to the medical, psychological, and familial implications of genetic counseling or genetic contribution to disease. So it has a cognitive, intellectual knowledge aspect to it, of course, but it also has that coping, adapting aspect to it that you will remember from the psychotherapy or the counseling definition earlier on. So it is very much counseling with an extra bit of knowledge about the genetic contribution of the disease. Now, I'm not saying that genetic counseling is psychotherapy. I don't think it is. But what I do strongly believe is that genetic counseling is psychotherapeutic. And this is not new. Kessler said that in the 70s. This is absolutely not breaking new information for anyone really. But what I think it is maybe a bit more of a recent focus on the counseling aspects in the genetic counseling process. So we're trying to revisit our roots, our identity, our professional identity, and who we are as professionals and what we do best. And this is very much what I'm trying to maybe remind everyone here today. And we know this and have known this for a long, long time. So we know this from the counseling skills and competencies that all the international professional organizations make sure that we do in our training, in our practice, and the fact that we are trained to use empathy skills to establish reports. We are taught to provide unconditional self-acceptance. We are taught to provide psychological supports. We are taught and trained to make sure we have a consensus agenda and goals with our patients, that we help them and empower them to make decisions, that we help them to cope with the difficulties they have themselves personally or their family. We try to make sure they have a good quality of life, and we help with their psychological well-being. All these things we really have known for many years, and professionals and our colleagues around the world train genetic counselors to do this every single day. And I think you will agree that most concepts here and most of these skills are not specific to any form of psychotherapy. So it's something that we do quite well. You will see in a minute, for a long time. I think we just need to remind ourselves that we really do that. And maybe that should be or can be a focus in our practice. Like psychotherapy, genetic counseling is rooted in many different traditions, and many of us use different models, and that's absolutely fine. As you will remember, there are no significant differences between various forms of psychotherapy, so it's absolutely fine that our genetic counseling practice tends to be rooted in different counseling models as well. And we can, and we are, using all these theoretical frameworks and all the empirical evidence available from clinical psychology and psychotherapy to improve our practice every day. Now, the literature to approach the psychological aspects of genetic counseling was not huge to begin with. So if you look at the literature in the 70s, in the 80s, there wasn't much there, but more recent papers and more recent evidence have shown us that there is huge interest, not only in the theory of the psychotherapeutic aspects in genetic counseling, but also to show empirical evidence that this is the main factor driving the success of genetic counseling. So not only we know that genetic counseling is therapeutic, but we have evidence to show that when we ask patients what is the most important thing for them in genetic counseling sessions, they always give us data and details and information that the most important outcomes for them are those of psychological nature. They feel that feeling adjusted or healthier or more balanced after our sessions is essential. The level of empowerment they feel after the session, whether they change a behavior or not, adopt the screening behavior, for instance, whether they feel happy with the session we just had. So the psychological outcomes following a genetic counseling sessions are the outcomes that stay with the patient. They may remember some information as well, but what they will remember the most is how we made them feel rather than what we said. That's not to say that is not important. It absolutely is. But in terms of what the patients remember, in terms of what stays with them after the genetic counseling session, it is very much the psychological nature of the session, of our interaction. What they find most helpful is finding someone who finally understands them, who sees them, who instills hope, who uses that 40% outside session more often, who uses their hope to get better, their expectancy for some sort of a solution or hope, or at least connecting with someone that understands them. So I think what we also know, and this is something that I think it's particularly important for those of us sometimes maybe more cautious of a heavy psychological based session, is that meeting the emotional needs of a patient seems to help their understanding of complex information. So if we help them feel less anxious, they will have more resources to actually understand the complexity of the information we're trying to explain in terms of risks, in terms of behavior, in terms of screening, in terms of treatments or other options. So trying to have that bond with them first helps us do the session or address the main referral reason that they came to us in the first place. So it really is that catalyst that we need to complete or to have a successful session. And we now have really good evidence to show that the importance of the genetic of the relationship in genetic counseling. And there's empirical evidence to show us that there are outcomes that are significantly improved following a good genetic counseling session in terms of lower emotional distress, more informed decisions, better knowledge, greater empowerment, greater patient engagement, and higher levels of satisfaction. And there's, as I said, absolutely solid evidence for that. And I think even more so, if we think not only at the psychological outcomes that we know are there, we also see medical outcomes and improvements that follow the psychological outcomes and benefits that we see. We tend to get more accurate and more thorough family histories from patients that have a good relationship with us. They tend to adhere better to screening or management options. They tend to access more guideline appropriate testing. And we tend to, or as a diet, if you will, but there's a less misuse of genetic test results because you do spend that time addressing, personalizing the information that you want to convey to a patient in a very personal, relatable, human way. Now, of course, it's easier said than done, and I do know it can be quite challenging to sometimes prioritize, at least theoretically, if you don't do that implicitly, the psychotherapeutic dimension of the genetic counseling session. And some of the challenges that we hear of is the very limited time for sessions, in the sense that we have a very heavy caseloads and we only have just a bit of time. It's very hard to add in the psychological dimension as if it's an ingredient that you just add at the end if you have enough time to do that. Well, there's evidence that focusing on psychological aspects in a session does not prolong the session at all. And I'm very happy to send that. So time, although it feels like a pressure, and I'm absolutely sure that it is, it's not an impediment really in trying to have a more psychotherapeutic focused session. We also know from the literature that clinicians tend to be a bit more comfortable providing education-based session. It's a little bit more didactic. The power level there is not as collaborative as it could be, and sometimes it's quite comfortable to teach patients or to provide information that is very clear, that is very solid, without necessarily delving into deep emotional conversations. And some of the reasons are absolutely valid, because people will say, what if there's something I cannot handle, something that appears in the session and I don't know what to do with that strong emotion in a patient? What if I can't contain it? I bring it up and I can't contain it. What do I do? Or what if it brings something in me? Like, what if I feel something and I'm not entirely sure how to deal with that? Or we might even think, was I actually trained to do that? Like, do I have the knowledge and the skills to address something as deep as? And you can think of many examples. So we tend to be, as a profession, quite a lot in favor of a more education-based session. But we also know that the level of self-efficacy can actually be improved with additional training, with mentoring, with supervision. And I'll give you an example or two in a minute. But we do know that that is a challenge to be acknowledged. And technology, and I think the last 2 years have taught us quite a bit that maybe technology is helpful, but maybe it can be an actual impediment, and maybe online conversations, online sessions, telephone sessions are not ideal. And we have chat boxes and we have all sorts of technological tools that we now use. And that can be seen also as an impediment. And I'm pleased to also say that is something that can be addressed, and there's some evidence for that. I'm not going to go into too many details. I'm almost doing a small advertisement here, but we did a meta-analysis looking at the efficacy of online genetic counseling. It's not published, that's why I'm showing you this slide. We're going to present the results in a couple of days in Vienna. But I'm very pleased to say that online genetic counseling is efficient. There's absolutely no evidence to show us that we are less efficient or less capable to establish a report with the patient, even if it's an online intervention, even if we see the patients online. That said, there is a small difference between video consultations and telephone consultations, and I think the results speak for themselves. I'm not going to go into too many details, but the efficacy of online genetic counseling is there. So although technology can seem a bit off-putting for even discussing deep, intimate issues, as we often do in clinical consultations, there is strong evidence to encourage us to keep doing it, because we are doing a good job. So I think, whilst I acknowledge the challenges that are there, and I know what the data is telling us, I think there is reason to really look at the opportunities and to really look at what can be done. I think for someone who's trying to be a bit more mindful of the therapeutic relationship. And I hope, if not myself, but maybe the empirical data available will assure you that being mindful of the therapeutic relationship really does not interfere with the primary reason of the referral, or what may seem to be the main focus of the session. It does not distract us from that. It does not take longer. If anything, it supports it, it helps it, it makes it better. And there are many things that we can do to make sure that we have all the skills that we need in sessions or for our patients. The multidisciplinary teams are always a good thing to do. And I know that every country is different, every center is different, every team is different. So there will not be a one size fits all, absolutely. And we have to, I think, just make sure that we have the skills and the expertise available for the patients that we see. And sometimes we really have to be creative in terms of how we deliver that. And it will be different in different settings. But as I said, probably MDTs will be a good solution in some cases. Making sure that we provide the adequate training that is needed, just in case there are questions in terms of how to deal, for instance, with strong emotions, or if someone needs some support in terms of additional training. But mentoring is also very good, and making sure that we have some mentors available, either mentors in terms of genetic counseling, someone with more experience than us, but ideally having mentors from clinical psychology and having mentors from psychotherapy or other counseling approaches, because that really enriches our practice, and it just makes sure that we pick the best from every discipline that is related to ours. And of course, counseling supervision. And it's something that we really need to make sure we provide and make sure that is accessible for everyone. And by counseling supervision, I don't mean clinical supervision. I don't mean someone making sure that we do a good job in terms of explaining things or prescribing tests, or making sure that the technology or the resources we use are adequate or in line with the protocols that we want to use. But counseling supervision, making sure that the heavy duty emotions, difficulties in our patients and ourselves are addressed and not just hidden under a carpet, hoping no one will see it, because it does tend to come out in the worst possible times. And there is, again, strong evidence that counseling supervision helps practice. And there are international guidelines for that as well. So I think, again, there's not one pathway, there's not one size fits all. And different centers will be quite different. And I certainly have at least the experience of 2 different countries, never mind centers. So I do know it can be you have to be quite creative, but there are ways around it. So I'm not going to talk any longer. I don't see on my screen any time, so I hope I'm not too short or too long already, but I'm doing my best. But I think I will end by concluding that genetic counseling really is, without any doubt, therapeutic. And there is strong evidence to believe and to practice this. Counseling relationship really is the main catalyst for the genetic counseling success. And if you are to bet on something, on a key ingredient in your clinical sessions, I would put my money on counseling and the therapeutic relationship. If everything else fails, this will not. And that's me. Thank you very much for your attention. And I'm happy to answer any questions if there are any. So thank you.
Thanks, Ramona, for this great talk. I'm sure the audience will have comments, questions for you. I'm just looking for the chat. If anyone, the audience, no? Can I start with the present here? If you have any comment, question, Professor Pablo? No, I thought you were. You were looking for the chat, sorry. Do you think so? Oh, I was asking for questions or comment through the chat. Okay. I'm not having access to the questions, is that right?
This is my water again. And it's
No. Okay, no. Okay. No, it's my question. Okay. So we can start with I don't know if any one of the participants remotely would like to share thoughts, comments. Yes, because otherwise people who are attending online
Oh, I
not
see.
here.
Thanks, Professor Ramona, for the excellent synthesis of information about the special relationship that exists in genetic counseling. Sometimes genetic counseling is a critical life event and it opens the way for very hard emotions and for change and for growth, for personal growth. But my question was about detailed about supervision, counseling supervision, and clinical supervision. You make any specific distinction between clinical and counseling supervision, and the role of mentoring systems in clinical settings? How has been your experience or opinions about that? But it was extraordinary to hear how you get a very complex topic in a very simple and clear way that I think we all understood well, the idea. Thank you.
Thank you very much. Thank you for the opportunity to explain a bit more, maybe some of the things I wasn't able to be very clear about or give you maybe enough details. So I think in terms of supervision can be has many forms, of course. And I think trainees and people working as junior genetic counselors or junior doctors needs all the help they can get. And there is a level of clinical or medical supervision that everyone has, and that is trying to make sure that we adhere to the protocols set out by the settings or the guidelines or the hospitals where we work. And that's absolutely fine. Just trying to make sure we have an evidence-based practice. We apply the best evidence there is with the best support we have in our center to the patients that we see. And I think this is probably the most common form of supervision people have. Now, in genetic counseling, in psychological counseling, in psychotherapy, we also do counseling supervision. So that is a supplementary form of supervision that we have to make sure our colleagues, ourselves, have access to, because that helps address the difficult emotional accidents, events, difficulties, which is normal practice for us every day that happen in our practice, just making sure that we know how to address it and we can debrief ourselves and we have someone to make sure, just like our patients are heard, just like our patients are seen, we need to make sure we have room for ourselves to do the same, to make sure, again, the best practice is in place, but also that we don't burn out. That we share our experience with our colleagues, and there's a level of peer connection and supervision as well. So for genetic counselors, for psychotherapists, they usually have a psychologist that tends to be their supervisor. I know it works different in different countries. In the UK, for instance, so I was born in Transylvania, in Romania. I worked there most of my life, really, and I now work in Manchester. So it's different in both countries. So if, for example, in the UK, everyone has access to either a one-to-one supervisor, a counseling supervisor, or a group supervisor. So you can, depending on what your needs are, depending on the resources of the department you work in, so you can absolutely have that. And it's something that is being paid and put in place by the department, of course. But also, we have to be conscious that not everyone does that and not everyone has that opportunity, because maybe it's not as traditional in other countries. So sometimes groups of professionals tend to gather and arrange supervision for themselves. And that has happened in Romania, that has happened in Spain, I know from colleagues. So sometimes you have to arrange it for yourself until the system arranges it for you. So there's top down, but also bottom up changes. I'm always for the bottom up changes. I can't wait for the government or the system to arrange a solution for me. So if I know there's something I need, I will probably try very hard to arrange it in the best possible way until it becomes the common practice. So I think if people have, that's great. But if they don't have access to counseling supervision, I can't recommend it enough. So hopefully that will inspire some people, if they don't have it, to maybe arrange it.
Great. Can you please take off the slides? So, and we have a question from here.
Yes.
Thanks for a great talk. I work as a specialist genetic counselor in Ehlers-Down syndrome in UK. Sorry. I'm interested in providing more support for patients after they receive their genetic test results. And the current funding system means we have limited resources to provide this. Genomics is being mainstream, and I feel this post-test counseling could be a big part of our role going forward. How do you see the psychotherapeutic dimension of genetic counseling role evolving in the future?
Oh, Claire, this is such a good question. Thank you. You're putting me on the spot here. But I think resources are always going to come into any conversation we have for in terms of support or long-term support for our patients. And I think the resources we have to see our patients at the minute are minimal. And if we think of our own practice and how many follow-up sessions we feel we need, or our patients feel they need, I think we all agree that the current funding, and I think I speak for most countries here, does not begin to cover it. So I think in my experience, probably the best way to address this is making sure we liaise with several other organizations, whether that's hospital-based organizations, whether that's charities, whether that's professional organizations, or anyone who can help provide the psychological support that our patients need. So ideally, we would want to have the resources we need to keep seeing them and to make sure we can arrange as many follow-up sessions as we need. But if we can't do that, and that is often the case, I think liaising with different organizations and different services in the NHS, for instance, but in other countries or in other systems as well, is probably the most creative idea, but also in line with the evidence and the resources available. I hope I sort of answered your question, Claire. Thank you.
Thank you very much. That's great.
I think Professor Paula Freitas, the director of the master course,
Just
would
a
like
small comment, because I think that all we are learning about this subject. What is it? Counseling supervision, what is it, clinical supervision. Milena also has doubts and wants to know a little more to clarify these two concepts. Anyway, do you think that counseling supervision is more concerned with the way how people integrate information about their own genetical problem? And the clinical supervision, it's more concerned with the emotional dimension of the problem. Do they understand what is, what do they, are they able to integrate the information about their disease or not? And if this difficulty concerns more an emotional dimension than any other. I don't know.
I think I understand the question, but please interrupt me if I don't, or if I didn't get this quite right. I think counseling supervision is very much aimed for professionals. So I think trying to make sure that the professionals providing genetic counseling have access to supervision themselves is important. So counseling supervision is something that we try to make sure the professionals, the clinicians have in place, so that they're in a good place in terms of knowledge, in terms of skills, in terms of personal growth, to provide the knowledge and the skills they have to the patients they see, so that the patients can benefit the most from the interaction they have, or the genetic counseling sessions they have with the clinicians they see. And I absolutely would agree that indeed, I think having a very intense emotional reaction in a session can interfere with the level of understanding or the level of focus you may have or not, in terms of information you receive or options you're presented with. So attending those emotions or strong emotions first and establishing that bond, that therapeutic relationship, can absolutely help our patients to then understand better what we're trying to explain or show or provide to them in terms of opportunities, options, services, screening, management, testing, and so on, or lack of. But you absolutely need to be in a good place to be able to receive all of that information. It's easier said than done. I do know that, but I think it's absolutely essential to address. Thank you.
Anyone else? I think we have time for last.
John Weil, former director of the Master's Degree Program in Genetic Counseling at the University of California. Ramona, this was masterful. Thank you. Given all the emphasis on the psychosocial component of genetic counseling, is an opportunity for me to talk about something that I'm now very much interested in and working on. Genetic counseling had its origins as a profession in the United States in the 1970s, and it is now truly international, although unevenly distributed. And my feeling is that given that it is now truly worldwide, it's important to take appropriate measures, and I put it that way because there are plenty of aspects of this, but to take appropriate measures to decenter it from the Western worldview that from which it originated and which still has great importance worldwide, and develop methods and techniques that are as well centered on the many diverse communities that are now served as were the initial, the beginnings of genetic counseling in the worldview and the backgrounds and the communities that were served in the 1970s when it was initiated.
John, thank you so much for your lovely comments. And if you thought my presentation was decent, I can only invite you to learn from the best and make sure you are up to date with everything John has ever written on this topic and more. So coming from you, it means a lot. Thank you very much.
I'm sorry, Ramona, I'm going to correct you. I didn't say decent, I said master.
Thank you very much.
Great. I think we have a last comment here and question. Thank you, Professor Ramona. She's a medical geneticist from Portugal. And thanks to the organizers for the insightful talk about the psychotherapeutic potential of genetic counseling. I'm a clinical geneticist, and we need to reflect deeply about the challenges we face. Can you please comment on genetic counseling in mainstream genetic testing? Thanks, Juliet.
Thank you very much for another difficult question. It's really, really important to address this, Juliet. Thank you very much. And I think it also, if I may, it just reinforces the fact that that therapeutic relationship is something we can all learn to develop, to grow, and to provide to our patients. You don't have to be a psychotherapist to have a good therapeutic, working, collaborative relationship with your patients. You don't have to be a genetic counselor to have a therapeutic relationship or counseling relationship with your patients. You can be a GP, you can be any professional that offers mainstreaming, for instance, genetic testing. This is a skill that any of us can learn. So this is why further additional complementary training is something that is really important to address. This is why counseling supervision is important. This is why mentoring is important, to make sure that this huge aspect of what tends to be responsible for the genetic counseling success can be replicated and can be offered by our colleagues. It's very much trans and interdisciplinary. So it is a skill that can be learned. It is a skill that can be, I think, taught, mastered by any of our colleagues, clinicians, patients, professional facing patients. So I know it's not necessarily an easy task to arrange, but it's absolutely something that can and should be successfully done and available to our patients. And I agree, mainstreaming doesn't make things necessarily easier, but all we have to do is learn and adapt and be creative and just make sure that we provide our patients with what we know they benefit most from. And this is absolutely, my money is on the therapeutic relationship, I have to say. So thank you for the opportunity to discuss this as well. And thank you, Claire, for that example. It's not a comfortable exercise to do. And I don't know, it's probably we don't have too much time, but it would be interesting to know what your deepest thoughts were. I know when I first did that example, I absolutely wrote my secret in Romanian, thinking that if they do dare to collect the tickets and our notes, they will not understand what I wrote. So at least I had something to cover my back. So I don't blame you if you wrote it in Morse code or if you did not do that at all. But it absolutely is such an intimate encounter. And I think we need to remind ourselves every now and then what we're asking really when we see our patients and what the best way to do that is or could be.
Thanks, Ramona.
Absolutely,
Really great
Claire.
moment. Thanks to everyone who is attending online. We need to move outside because the room will be used right now, but we can continue with her for those who are here. Thanks for this great moment and the opportunity to be discussing about this interesting topic. Thanks, Ramona.
Thank
Brilliant,
you.
as I thought.
Thank you very much.